It's give me great pleasure to introduce Professor Anurag Agrawal. Forgive me if my pronunciation is too much off. But at any rate, I got to know him through reading magazine, Nature magazine, on June 1st, when he wrote a worldview to Nature. That's a very outstanding commentary, very well written. And I remember he concludes that science must adapt. Yes, indeed. In the time of COVID-19 pandemic, we people living in this planet all face the same serious challenge in the world. We need to communicate, learn from each other. Thus, I recommend Anurag to be a speaker, and I'm so happy he instantly responds, say, yes, I'm coming. So here it is. So Dr. Anurag Agrawal is currently the director of CSIR, stands for Council of Scientific and Industrial Research, in the Institute of Genomics and Integrative Biology. He completed his graduate medical education in India in 1994, and he received very complete medical training, internal medicine, pulmonary disease, critical care at Baylor College of Medicine, Houston, USA in 2003. And then he got his Ph.D. in physiology, from Delhi University. Anyway, Ph.D. is a doctor of philosophy. He has a primary interest in respiratory biology, and broader interests are in a new vision where the health and healthcare can be seen through the emerging technologies such as genomics and artificial intelligence. Dr. Agrawal serve on national think tank, and as well as experts on international positions, such as a co-chair for the Lancet and Financial Times Commission on governing digital health futures, and serve on related expert group at the World Health Organization, WHO, and Global Partnership for Artificial Intelligence. He received many outstanding awards, including Shanti Swaraj Bhattacharya Prize in 2014 on his outstanding achievement on the pulmonary medicine, and also Sun Pharma Award 2020. And he's an elected member of the Indian National Science Academy and also the Indian Academy of Sciences. So today, I think we have the fortune to have him because he really understands the situation well on a global view. And his topic for today is lesson from the Delta wave for future pandemic preparedness. Ladies and gentlemen, let's welcome Professor Director Anurag Agrawal. Please.
Thank you very much, Peter. It's been a pleasure to be able to join here with this audience. And I look forward to sharing what we learned about Delta from a very severe outbreak in India. I'll start with this picture of Japanese schoolgirls wearing masks. There is a French quotation, which basically means the more things change, the more they remain the same. And this picture is actually not from COVID. It is from more than 100 years ago, at the time of the Great Spanish Flu. The Spanish flu actually was far worse than SARS-CoV-2 in terms of mortality. Here, what you see on y-axis is percentage of deaths. On the x-axis, you see age groups. And what you can see is the deaths in the flu pandemic was very focused in the particular age group of moderately young people. Now, this is very, very different from what we see for SARS-CoV-2, where age has been one of the biggest risk factors for dying. Why this difference? The difference is that older people during the time of the Spanish flu had some immunity because of a previous version of the flu that was relatively similar that had come 30 years ago. Unfortunately, in the case of the SARS-CoV-2 pandemic, cross immunity from previous infections has been minimal, except perhaps pockets in East Asia. And effectively, for most of the world, there has been no effective background immunity, although we have seen some degree of T-cell responses in people who are naive to SARS-CoV-2, but we'll come back to that later. And so what is the reason that SARS-CoV-2 has become such a big problem that has pretty much brought the world to its knees, and particularly now with the Delta variant? The first is it's a respiratory virus, minimal prior immunity, very high transmission, high RT, and huge numbers got infected. But that alone possibly would not have got us to where we are today. You know, when evolution of a RNA virus occurs, you can get lucky or you can get unlucky. With SARS-CoV-1, we had some degree of luck that perhaps more fit variants did not emerge. Here, in SARS-CoV-2, we have seen evolution of the virus to fitter variants with greater airborne transmissibility, reduced susceptibility to immune response induced by the previous variants, whether these be via natural infections or by vaccines designed against previous variants. And these massive surges by highly fit variants, one of which is Delta, have overwhelmed healthcare systems despite no real change in what is a fundamentally low infection fatality rate. And you will see that as I go through my talk. And genomic surveillance has been instrumental. I don't think we had this level of genomic surveillance in the world ever, by which we have been continuously identifying the viral lineages, new mutations, investigating spreads, clusters, and even understanding by now, to some degree, which mutations are likely to increase infectivity or immune escape. We still don't have a clear understanding of severity. And WHO, of course, has been pushing a lot for every country to have a strong genomic surveillance program. And each country is asked to look at itself in three different things: the diagnostic capacity, the sequencing capacity, and sequence data analysis capacity. Only if you have all three are you truly capable of conducting genome surveillance. India is somewhat unique amongst low to middle income countries in the world, that while the average income levels are on the lower side, the scientific capacity has been relatively well built to the point that we've been able to have high levels of testing. Not high, but at least modest levels of sequencing, and very good capacity for data analysis. I'll walk you through what we saw in 2021. In 2020, we had only sequenced about 8,000 samples. Multiple labs, including mine around the country, were making small efforts. It was not that clear or obvious to anybody in early 2020 that this was going to be very important. Even in early 2020, we identified a new variant now called B.6 by pangolin nomenclature. It wasn't a variant of concern. If anything, it was a less fit variant that had a super spreading event. After the discovery of the alpha variant and the beta variants in UK and South Africa, India became very concerned about such variants entering the nation. And we formed a national sequencing consortium, which we call INSACOG for short, using which about 80,000 samples have been sequenced to date, which about, I think, 60,000 are available on GISAID as of now. Unfortunately, we did not start fast enough and look inwards enough to completely identify the kappa and delta variants in time, but we did manage to make some identification for the world. So this is how things were until April 2020. Apart from one mutation in the spike protein called D614G, nothing else really had that much significance in most of 2020 until you got the alpha variant towards the summer, November, December of 2020. At that point, we were not calling things VOCs. Otherwise, all G strains, anything that starts with B.1 contains this D614G. And you can see the letter G in the next strain nomenclature. These G nomenclature strains pretty much took over the world. This was the first VOC that is never quite recognized as such. But this mutation was possibly critical in determining the rate of spread of SARS-CoV-2. I think if it had not happened, we would have been looking at a very different story. Now in India and in Delhi, like the rest of the world, we had some degree of suffering in 2020. And you can see here the first wave that pretty much ran from somewhere around May to about October. Delhi being a congested megacity with a population of almost 20 million people, underwent more than one waves because it would come down, then it breaks up again, huge amount of travel, migration. So we had approximately 4 waves till date. But let's come to January 2021, when I will start showing you some data. In January 2021, you can see cases in India, cases in Delhi had almost disappeared. We'd already been through what appeared at that point in time to be through multiple outbreaks. And we had a seropositivity of about 56.1% in Delhi in January 2021. Within a cohort of our employees, which are about 1,500 employees, which extends other labs, which are my sister labs, we had a seropositivity of 42%. We had started vaccinating healthcare workers in January. We had opened it up to elderly people in March, and general population was about to start in April. And looking at the seropositivity, most people thought the worst was over. Unfortunately, around that time, in another state of India called Maharashtra, probably the size of 3 or 4 European countries, with a population of at least 100 million, a mutant sequences were starting to get seen, which contained in the spike protein these important mutations, one of which was L452R, which had previously been described in California in December 2020, leading to about a 20% increase in transmission. It was expected to stabilize the spike protein ACE2 receptor binding. We also saw this mutation E484Q, which was not 100%. In about half the samples, the mutation was there. It was very similar to E484K mutation in South Africa, which is now called beta, the beta strain. And that leads to strong immune escape. We also saw a third mutation, P681R, which is close to P681H, which had been described in the alpha variant in UK. To increase spike 1, spike 2 cleavage, nobody quite knew whether 681R would be as strong as 681H. Now we know it is even stronger. But in any case, what we could see was something that looked like this. We could see number of cases in the state of Maharashtra. And remember, India is not seeing many cases. Started rising, not huge amounts. From 2,500, one went to slowly 10,000 over the span of a month or so. And along with the rise in this lineage that was later in April given the name B.1.617, also rising side by side. So in March, India released a note that we are seeing a new variant, which may be driving an outbreak. But as you can see, it was about 25% of the genomes, not dominant at that point in time, but associated with a temporal rise in the number of cases. In April 2021, based on inputs provided to the viral evolution group, of which I am also now a member, WHO recognized this lineage B.1.617 as concerning It got split the next month into two further lineages, 617.1 and 617.2. 617.1 is called kappa, 617.2 is called delta. 617.2 had lost E484Q and gained T478K in the spike region. These mutations look to be concerning to us based on structural modeling done by Dr. Lipi Thukral at my institute. Reason being they had the N-terminal deletions previously seen in alpha with strong immune escape. They had mutations L452R, which stabilizes the binding with the ACE2 receptor. And the also .1 had the E484Q that also helps in immune escape. And importantly, in the furin cleavage site, there was that P681R that was expected to perhaps, along with T478K, accelerate the cleavage. So binding would be stronger, cleavage would be faster, and previous antibodies may not work. Around the same time, we noticed that in a fully vaccinated cohort of healthcare workers in one of our hospitals, there was a vaccination breakthrough clusters. All the dots you see in green are light green, are 617.2. What you see in dark green is 617.1. What you see in dark blue are fully vaccinated. What you see in intermediate blue is single vaccination. And light blue are people who chose not to be vaccinated, although vaccination had been offered to everybody. The first very important thing, and this is AstraZeneca ChAdOx1 vaccine, it immediately struck us that 617.2 was able to create a cluster in people who were otherwise vaccinated and had interacted with masks off over the course of a single day for a gathering. So it became an important observation, and 617.2 was immediately upgraded, and this event occurred in April. By May, 617.2 was recognized as a VOC by WHO. Unfortunately, by that time, it was perhaps a bit too late for Delhi. This is a bit of a complex graph, but let me walk you through it. The bars reflect the number of tests being done in the city of Delhi. You can see we were doing a large number of tests, about 500,000, 500,000 tests starting in this time period. The blue tips show you the number of positive tests. The red line shows you the test positivity rate. And what you can see is we went very fast from maybe something like 200 cases a day to something like 20,000 cases a day in the span of 2 weeks itself. So by the time we realized that we had a difficult variant on our hands, we were right in the middle of a massive outbreak. This massive outbreak led to hospitalizations and ICU admissions as shown over here. And you can see the graph of hospitalizations and ICU admissions. The ICU admissions has become unnatural. At this point, it just flattens out. And the reality of that is we had no more ICU beds. So at that point, we started, bringing in all kinds of innovative solutions to increase ICU beds, but there were shortages everywhere in the city of Delhi. But all through, the number of infections and the number of deaths, when adjusted on scales, stayed proportional. You can understand that deaths will be separated by number of cases because they don't occur instantly. But when you shift them together and put a cumulative curve, you can see they rise almost in perfect synchrony, suggesting this new variant was causing massive number of infections. Because of massive number of infections, many of which may not even have been picked up, it was leading to a massive number of severe cases. But at the end of the day, the percentage of people dying remained the same as it had ever been in the past. Because we had a strong sequencing program in the city of Delhi, we were able to generate sequences, and I think I managed to put a slightly wrong graph. It doesn't really matter. So I got cut, but the numbers are in thousands and hundreds, not in these numbers. But what you see is that 617.2, light purple, delta, rapidly overtook every other type of sequence. Before April, Alpha, which is the variant first seen in UK, and at that time, the most transmissible variant in the world, was prevalent in Delhi. But as soon as Delta came, Alpha almost disappeared from the city of Delhi. And you can see the rise of Delta, the light purple, is strongly correlated with the high test positivity rate and the new cases. This is data for India. This started from Delhi, the big Delta wave, probably came in from Maharashtra. I'm not showing you that data today. And then went on to displace Alpha and Kappa, the previous variant, all over India. So light gray is Kappa, orange is Delta, yellow is Alpha. So you'll see in the beginning there was Alpha, then there was Alpha and Kappa, and little bit of Delta, and then soon there was only Delta and nothing else. So without any, high quality mathematics, what you can see is Delta is far more transmissible than Alpha, far. Within a month, it pretty much displaced it completely. And Alpha was already 1.5 times more transmissible than D614G. And D614G was at least 1.5 times more transmissible than the original strain from Wuhan. So you're looking at massive increase in transmissibility since the first outbreak in Wuhan. So again, for those of you who would like to see the data yourself, this is the link to the portal. You can see almost all of India's genome data pre-analyzed and visualized on this portal. The sequences are available to GISAID. The gap is usually small and usually related to quality of sequence. Few other things that we noted. The CT values dropped by about 5 during the Delta outbreak, suggesting somewhere around 50-fold, 10 to 50-fold increase in viral loads. Using very nice work with our colleagues in Oxford and elsewhere, we could show that replication rate was higher for 617.2 compared to Alpha. So this is Delta, this is Alpha. And if you were to grow them in culture, and here the green is Delta, the orange is Alpha, and 2 different clinical samples have been put into culture, you can see that the plaque forming units are far higher with Delta. But very importantly, I ask you to come back and look at the 24-hour time point. You are looking at an astonishingly higher replication rate for Delta. And even if you were to compare Kappa with Delta, the same things remain true. Infectivity is greater, which explains that, while Kappa was coexisting with Alpha, but not displacing it, Delta did away with both of them. We could also see, and this is work done purely at Oxford, because only they had access to the Pfizer vaccines and so on, which were not available in India, that neutralization of the virus by sera from people immunized either by the ChAdOx1, which is the AstraZeneca vaccine, that we had available in India, for which we had seen that cluster in vaccinated healthcare workers, or from Pfizer vaccines, which were available in the West, but not in India. Both of them showed loss of neutralization when it came to Delta. And this loss of neutralization was greater for Delta than it was for Alpha. Well, actually comparable, but a little bit lower, not significant perhaps. Here is the same data, but shown in Indian healthcare workers. To reach the same level of neutralization on the x-axis, you need 1 log-fold higher spike antibodies. All these people were immunized with ChAdOx1. 100, which means 2, is considered to be a good level of antibody. And people with about 100 units per ml are high titer plasma typically. What you can see is that there is almost no neutralization at the level of high, 100 units per ml. To get good neutralization like 1:40, 1:80, you're talking about 1,000 units per ml or more. And what you see here are actual viral neutralization studies done before and after the pandemic, with the surge in Delhi. And what you see is that many people were dark blue, able to neutralize the wild type strain, but almost nobody is dark yellow, until after the surge. And what we see is that 25% of the people who were fully vaccinated, healthcare workers with normal protection running, managed to get reinfected. And we can do that because we look at antibodies to the nucleocapsid antigen. Immunization only gives you antibodies to spike protein, which had OX1. It does not give you antibodies to nucleocapsid. So nucleocapsid antibodies tell you that you got infected. And this is something that we saw in 25% of healthcare workers. Using a lot of this data, we were able to build mathematical models along with Imperial College London, and we were able to show that the reason Delta variant was so severe, despite the city of Delhi already having nearly 60% seropositivity, 56% in the community, is because of a combination of pure transmissibility, pure infectivity, and because of increased immune escape. As you can see, the two things will be anti-correlated, and the reference is the background reference of Delhi, that will be alpha. And remember, I told you alpha is anyway far more transmissible than previous versions. So when I say times 1.5, it means 1.5 times of alpha, which itself is 1.5 times of D614G. So you're looking at something that is 2 times D614G, and which would then become 3 times of the original strain that came out of Wuhan. And what you see, of course, are estimates of how many the deaths were. Let's skip past that. So a question that is possibly in everybody's mind is, then when does it end? So these are seropositivity estimates in a cohort of employees in my institute, only the unvaccinated ones. And the number went down as more and more people got vaccinated. But what you see is that in January to February 2021, when I had about 42% seropositivity, it was well distributed between, private transport users had low seropositivity, public transport users had high seropositivity. After the surge was over, everybody was highly seropositive, and the average seropositivity was 86%. What we saw were there were many people who were seropositive in the first part of our cohort, whose antibodies were declining and then went up again. So that's reinfection. And we estimated that to be 28% of the population. And we excluded those people who never went down before they went up again. If I were to include that, we would see about 33% reinfections. So this problem is not unique to India. Many other countries in Asia, for example, Indonesia, also had high seropositivity. Many countries in the world had high vaccination, and Delta pretty much spread across the world. Whether developing, whether developed, there was a huge spike in new cases after Delta spread. The only good thing is that vaccines reduced mortality. If you look at time before Delta, time before vaccination, red are deaths, blue are cases. You can see red is a small reflection of the blue. But look at post-vaccination in well-vaccinated countries like UK, Portugal. You can see the red has not increased despite the fact that blue keeps on going up. In South Africa, where vaccination rates were low, you can see that when cases went up again, deaths also went up again. And that's the biggest challenge, that we must promote vaccination if we want to reduce deaths. And of course, multiple people around the world confirmed our observations that vaccine efficacy were low because they have very good public health data. They were able to come up with much more precise estimates than we were able to. And if I were to summarize the slide, I would simply say 1 dose of AstraZeneca turned out to be very, very ineffective. Well, 30% effective, which is not very effective. But when you look at efficacy against hospitalization, it retains effectiveness. So even 1 dose can give you more than 60% effectiveness against hospitalization. So severe disease is effectively prevented by vaccines. Once Delta comes, simple infection, less so. And this led me to talk about what Peter introduced the article, that there is a huge need across the globe to forecast variants. There has to be a greater emphasis on genomic surveillance, informatics for alerts. How could we have done better in identifying the Delta? We did the structural analysis. We just didn't realize it will be this bad. deeper integration with clinical data for early confirmation, and integration of diagnostics with variant determination for actionability. If you send things for sequencing, the results come back later, and that sometimes is too late for you to do anything about it. So I'm happy to say there is some work, at least from our lab, that shows how CRISPRs can be used even in low resource settings to do variant detection. I invite you to take a look at that paper. But on the whole, it will take a very comprehensive set of lessons that I hope our experience can tell to the rest of the world to do better the next time a variant like Delta comes around. Thank you all very much. Happy to take any questions.
Thank you very much for this very powerful presentation. Let's check the time. Jenny, how much time do we have left for this slot? Jenny. So
we may have 15 minutes for Q&A.
Thank you. Anurag, maybe I have the first question about the rapid diagnostic with the CRISPR technology.
Sure.
I read about it, and also there's some US company or also have similar announcement. What's in your mind how to combine both the genomic surveillance with CRISPR diagnostic?
Thanks, Peter. Great question. So there are two parts to CRISPR. One is a diagnostic that you have SARS-CoV-2, and the second part is a diagnostic for a variant. So let me recap the things available. The first CRISPR diagnostic for SARS-CoV-2 was Sherlock from Fang Zheng's lab. And what it does is it recognizes and binds to RNA directly. It's a Cas12, and then undergoes an activation and then does a secondary amplification cleavage, which allows a very, well, about 45-minute total diagnostic for SARS-CoV-2. And Sherlock was introduced but hasn't quite gained commercial traction. Perhaps pricing has been one big challenge because normal PCR has dropped so fast in the course of the pandemic. The second one of the same line was Detector on very much the same principles. That came from, of course, UC Berkeley's lab, the Doudna lab. And that also is similar. We took a slightly different approach to SARS-CoV-2 diagnostic using CRISPR, partly for patent reasons and partly for another reason. We were trying to look at a very high single nucleotide level specificity. So what we do is we use a FN-Cas9, which was came out of a collaboration between my institute and Japan. It is possibly the most specific CRISPR known. It effectively binds to a known sequence like an antibody, and then it's part of a lateral flow strip assay like an antibody test to give you a band. Because the binding is so specific, even a small variation allows us to create second strips, which are targeted to specific mutations only seen in variants of concern. So for example, here for N501Y, which at that time in India and the world, everybody was talking about alpha and N501Y mutation. So you could see that we could create a set of two strips such that the first strip would only give you a band if it bound to the wild type SARS-CoV-2 conserved sequence that is not different between the variants, while the second strip would only give you a band if the N501Y underlying mutation was present. So we could create these kind of paper strip without any qPCR machine type of diagnostic. But what turned out is that we are not able to reduce the cost, the purchase cost to us below $5. If we cannot reduce the cost below $5, an RT-PCR test in India are now selling at $1. Then it's a bit difficult to create a market. But we are hopeful. So WHO has taken up this technology under what they call the CTAP, Common Technology Access Platform, to possibly make it available in the rest of the world, where perhaps $5 is not a huge number, and prices have not crashed to the $1 level. So maybe there is a market for it still. But these are the differences between the three CRISPR technologies that I'm aware of that are in the market.
So I would like to know from the meeting administrator, do we have any question from the audience on the internet? 有没有看到贴任何问题? So please don't be shy. You can ask question in Mandarin, Chinese, and we can translate. Yeah. Anurag, I think your last comment about seropositivity is high. That means a lot of people already exposed to the virus. And the question is, do you think how would that affect the vaccination strategy?
That's a really, really good question. And what we see, and I didn't put the data over here, if people are vaccinated, a single dose of vaccine takes them to levels in thousands in terms of their spike antibody, anti-RBD spike in units per ml. Thousands. Just one injection. So which basically means, and if I were to look at the risk of infection of people who were both previously infected and vaccinated, that 25% number I talked about in the previous slides here, this number 25% becomes 2% for people previously infected and vaccinated. So yes, vaccination is extremely more effective in the background of high seropositivity. So my expectation would be that since India, the infections preceded most of the vaccination, and the vaccination came mostly in the general population after this huge Delta surge, we expect to see long-lasting, strong immunity for at least this year and hopefully a good part of the second. But I will warn that immunity comes down. So what you see here in panel B that I didn't talk about is a crude assay of viral neutralization using spike protein, which is a synthetic protein. What you see is people who had high inhibition in phase 1 of our study, when checked in the phase 2 study, which is 6 months later, many of them had gone into the negative zone. So that is something that we must remember, that no immunity is permanent. In this case, most of these people were only infected and not vaccinated, so they lost it in 6 months. Infection plus vaccination probably at least a year, but still, it's not permanent. So we might become endemic later on. But I think India is towards endemicity now.
So for most people in India who are already exposed to the SARS-CoV-2 virus, in other words, they are seropositive, do you think it's necessary to have 2 shots of vaccine, or 1 shot is good enough?
Going purely by data, our data suggests 1 shot is enough. The problem is that these are sample-based studies, right? So I took 1,000 people and I tested the sero status. But when a person comes to you, unless we create a new protocol for vaccination, which we test them for antibodies before we vaccinate them, it may not work. And then logistics are difficult at the scale of hundreds of millions to collect the blood, test for seropositivity, then call them back for the vaccination. And because India is a manufacturer of vaccines, we don't have a huge internal shortage of vaccines. So logically, it makes sense to do it this way to preserve vaccines, but practically, it's going to be almost impossible to do.
Understood. So any other question from the audience?
May I?
Yeah.
Yes, sir.
Tony, Professor Ken Wu, and then Tony is next. Yeah, Ken.
I have some simple questions, just curiosity. You presented that the Delta variants has several mutations.
Mm-hmm.
Well, the mutations on spike protein of course, it affects entry, and so it can spread faster, right?
Mm-hmm.
But which mutation can lead to the replication rate increase 3 order of magnitude? Do we know?
That's a great question. The most likely answer is P681R and T4. So this is the generic 617 story. So T478K is not here, but P681R. So in the Nature paper that we have with Oxford, and the reference is here. Let me show you the data. Yeah, this is the paper. What we see is that P681R was absolutely essential. And in the extended data supplement of this paper, you will see a very nice spreading of cell-cell fusion. So what we see is that P681R with or without T478K, we're not sure on that last part, leads to accelerated cell-cell fusion. And that probably leads to very fast replication.
I see. Yeah, that's possible. Which mutations result in a decrease in severity of the disease?
So the severity, as far as we can make out, is same as it has always been. So if you look at case fatality ratio, the case fatality ratio in the city of Delhi was to 1.8% before Delta, 1.8% after Delta with barely any change. But immune escape, the most important mutation seems to be the N-terminal deletion. And L452R has both abilities, both to create a bit more replication as well as a bit better binding, as well as a bit of immune escape.
Yeah,
So
I think the interesting question is that why during evolution will cause both mutations occur.
To come to the convergence. So we are seeing now around the world a convergence of mutations. So the initial mutations that give you advantage in a naive population are those of pure infectivity, because immune escape is meaningless. But later on, as immunity builds in the population, immune escape mutations, particularly E484K, starts being seen everywhere. So even if you look at UK, the original alpha was N501Y. Later on, it also developed the E484K. In India, developed E484Q. Many others. So immune escape mutations are secondary, probably driven by immune pressure, while infectivity mutations came early in the course of the pandemic, with D614G probably being the best example, then N501Y, then L452R, and P681R.
Thank you.
So Tony, do you have a question to ask? If not,
Please turn on the microphone, Professor Zhang.
Okay, I have one question. Okay, from your talk, we all know that people get previous infection or vaccinated. Okay, usually do not reduce the further infection too much, but however, it reduced the hospitalization and severe disease very, very much so. Is there any other reason besides the, just reduce the viral load? Do you have any other suggestions or educated guess for that?
I mean, one could guess that cell-mediated immunity is critical. And cell-mediated immunity probably kicks in and clears it from the target organs very fast. But the data for what is the exact role of preventing infection by humoral and initial escape versus clearing in the severe phase of the infection with cell-mediated, the data is not very good so far.
That is still not much so.
Still not much.
Okay.
But that would be magic.
Your educated guess. I think that's highly possible. At least will be one of the main reasons.
Yeah.
Okay. I really enjoy your talk very, very much. Thank you.
Thank you very much.